Good afternoon, friends. Uh, in a post-prandial state, we are having division of all small setup sessions in parallel halls. And this is something unique which we are going to have it over here. That is a webinar on tocotrienols. So there is going to be a simultaneous relay in almost 10 to 12 cities across India at the same time. So who would be listening to this seminar at that particular thing? There is a station kept at each these cities. So that is something unique which we are going to have. Because this session, which will be taken by none other than one of the pioneer or research work in the field of tocotrienol, and of course the organizing chairman for this API conference, and all of you know him, Professor Dr. Chandan Sen, and who has been, of course, last 2 days, he's been in the limelight for this organizing skill as well as the scientific content. So without much wasting time, may I call upon Professor Dr. Chandan Sen to start the proceedings with this webinar on tocotrienol. Sir.
Thank you, Ketan, and good afternoon. I should say good afternoon, India. All viewers from throughout the country. We ran a little bit late, so what I'm going to do is highlight some of the recent developments in tocotrienol. And please pardon me skipping some slides because we are running a little bit late, and it would be of interest to have enough time for panel discussion. So it would be my goal to finish by within half an hour. So we have another half hour for panel discussion. That said, tocotrienol. Now, vitamin E, obviously very well known to all of you. And vitamin E, the version that you have on the screen, is a phenol. And this phenol has a phytyl tail. And this phenol with a phytyl tail is tocopherol. And tocopherol exists, as we know, as alpha, beta, gamma, delta. And there is also a natural form, not a synthetic form, but a natural form of the same variation where you have the side chain. Instead of a phytyl tail, you have an isoprenoid tail. And this is not something that is man-made, this is nature-made. A very interesting way of looking at it would be most of tocopherol is found in the green leafy part, and most of tocotrienol is found in the seed part. And there was this very beautiful paper in Nature Biotechnology that if you just take away the tocotrienol version of vitamin E from seeds, then remarkably the shelf life of seed is diminished. And that's a big deal because seeds are supposed to be, so to speak, hibernating under non-favorable conditions, and they germinate under favorable conditions. So tocotrienol clearly adds, provides that feature to the seed. Another key point here would be that in addition to the 4 tocopherols, alpha, beta, gamma, delta, and 4 tocotrienols, alpha, beta, gamma, delta, we also have synthetic forms of vitamin E. Now, when you see DL, before a tocopherol, or toco, anything that starts with a toco, if it starts with a DL, that's a synthetic version. Also, if it will end with a YL, if it ends with a OL, it's likely a natural form. If it is a YL, if you go to the market, anything that starts with a DL, ends with a YL, it must be synthetic. A very long story, very short. Clearly, the body discriminates between natural and synthetic, and if you leave it to me, I would be more inclined to take the natural form and not take the synthetic form. With that said, let's move on to what's so special. Now, tocotrienol, like I said, is found in the seed form, so it's quite natural that you would have that in excess in certain oils. Why? Because oils come from seed. Now, one of the key suppliers of tocotrienol, if you will, to us is the palm oil, because the palm oil is very abundant in tocotrienol. And then you have all these other oils. You heard just a beautiful lecture in another session, in the keynote session, by Dr. Sam Parthasarathy on sesame oil. Here what you see is that even olive oil will have some, but very little. Palm oil, highly abundant in tocotrienol. Now, when I started getting interested in this, which was exactly now roughly 20 years ago, At that time, less than 1% of the vitamin E literature had to do with tocotrienol. Very few papers. It was something like 56 or 57 papers or so, a very small number. Whereas in vitamin E, tocopherol, there were tens of thousands. Now, that was way back when, 97, 98, okay, roughly 20 years ago. You see, though, from that time on, there has been a sharp rise, and this rise is for a good reason. And the good reason is there is clear indication that tocotrienols do things that tocopherol don't. I will emphasize more on that shortly, hopefully more during the panel discussion. But that is our sort of claim to fame of our group, where 20 years ago, we came up with an observation that showed that tocotrienol alpha tocotrienol, was about 1,000 times more potent than alpha tocopherol in preventing neurodegenerative conditions. 20 years have now passed. Many papers have been published. I was asked by the American Alchemy Society to speak at a session. That session led into a book, and that book borrowed one of my review titles. I wrote a review that is now cited roughly 500 times. It's called Vitamin E, Tocotrienols, Vitamin E Beyond Tocopherol. And on that topic, there is now a book. I wrote the foreword for the book, and the topic has really become quite popular now. Now, quickly, let's hit on some of the key points. I see here one of the posters, not my job to really promote anything here, but you see there muscle cramps. So muscle cramp, clearly, vitamin E seems to have a key role in muscle cramp, and much of the role of vitamin E in muscle cramp has to do with its role on neurological pathways. And as you will see during the due course of this talk, that tocotrienols seem to have much higher potency in influencing neurological pathways. Now, in addition to, of course, there are other alternatives that are currently in action, as you have quinine, verapamil, so on and so forth. Now, under these conditions, of course, vitamin E seems to be safe, and the result on muscle cramp is building. And I would think we are at a point where randomized clinical trials should be considered. Not only cramps related to cirrhosis, but also cramps related to the menstrual cycle, menstrual cramps, so on and so forth. And in this case here, tocotrienol really works by inhibiting the arachidonic acid metabolic pathway, which we have published extensively on. It works on PLA2, it works on 5-lipoxygenase. So there's multiple specific targets of tocotrienol. Also, there are some results indicating positive effect in the context of hemodialysis, patient cramps, also intradialytic cramp, and I already mentioned briefly the cirrhotic cramp. And I think we are at a position with muscle cramps where a randomized clinical trial is really warranted. Other data leading up to that is quite favorable, so the right study design should turn out to be quite productive. Quickly summarizing what we have with tocotrienols in cardiovascular disorders, mind you, I don't work on muscle cramp in my own lab. I do not work directly on infarction, so on and so forth, but we do work on cardiovascular because a big part of our work is on stroke, and recently we have found a remarkable breakthrough in the area of non-alcoholic steatohepatitis, NASH. So as we already know, tocotrienol is quite effective in blocking the function of HMG-CoA reductase. It influences the mevalonate pathway, lowers hepatic cholesterologenesis, as you see here. Going forward, there are some studies that are quite positive in the area of atherosclerotic lesion. You heard a little bit about that from Sam a few minutes ago on the development of atherosclerotic lesion and the mechanisms underlying that. Of course, one component of atherosclerotic lesion is oxidative modification of proteins, but more and more research that is going on currently shows not only does tocotrienol act as antioxidants, which was already envisioned some time back, the antioxidant-independent actions of tocotrienol, those pathways are also steadily growing, and seems there is a large list of pathways, one set of which being antioxidant-dependent, the other being antioxidant-independent. And finally, there was this study that was very interesting where not only did it correct, but in this case, it actually reversed certain dysfunctions caused by high carbohydrate and high fat diet, and here liver function, heart function, etc. Were studied. This is the study I was referring to. It was published a few years ago in 2012 in Nutrients. And this was a study that came up relatively recently, where it was shown that tocotrienol can actually break down HMG-CoA reductase, and in doing so has beneficial effect on Alzheimer's disease. So it's really not so much, it's really working on certain hub mechanisms that can be related to a number of pathologies. Now, any single laboratory usually studies only a limited number of pathologies, but if you take the sum total of the evidence, I think the time is really ready now into getting into randomized clinical trials, which are currently relatively few for tocotrienol. With that quick introduction, I will enter into the territory that originates from my own laboratory. My laboratory got interested in stroke because, like I said, when I was at the University of California at Berkeley, we used to be the laboratory of vitamin E that the whole world knew. It was led by Lester Packer. Merit Traber, a very well-known tocopherol scientist, also was in the same lab. I was in that lab, and my interest was directed towards tocotrienol. So what we did was we got from BASF blinded samples, 8 blinded samples, alpha, beta, gamma, delta tocopherol, and alpha, beta, gamma, delta tocotrienol, 8 natural forms of vitamin E. And we conducted some screening tests where we found sample C turned out to be extremely neuroprotective, So we had to do something about it, and we kept on trying in a number of experimental systems, and it turned out to be neuroprotective again and again. And now, for those of you who follow the work coming out of my laboratory, we have published extensively on small animals. We have gone into dogs, large animals, and then a whole bunch of clinical trials have started. And if you go to clinicaltrials.gov, many of them are listed there. The phase 2 trial on stroke patients have just concluded. The phase 2 trial on liver patients has just started. So we have come really a long way since then. This was one of the very early findings where you see what we reported in the Journal of Biological Chemistry in the year, I believe it was 2000, that 100 nanomolar tocotrienol, complete neuroprotection, 100 nanomolar. Even if you give the tocotrienol hours after the insult, so depending on the insult, even if you're insulting the neural cells with glutamate or homocysteine or what have you, you can rescue 100% of the cells with 100 nanomolar. Nothing that I know in the nutrition world at 100 nanomolar is effective, nothing. Okay? So this is extremely low concentration. A big criticism of tocotrienol field is that the amount of tocotrienol humans get in the blood after they eat tocotrienol is relatively low compared to what you have for tocopherol. So let me be a little bit slow here and make the point. So once you have tocopherol in your diet or as a supplement, it's not sort of surprising to have something like 15, 20, or even 30, or maybe 40 micromolar concentrations of tocopherol in the blood. Once you go to tocotrienol, all you can achieve is about 1 to 1.25 micromolar. That's all you can achieve. And people sort of discouraged, oh, well, it is too little. I say that doesn't matter. That's about 10 times what we need to protect our neurons. So it is not just about more is better, but what does it take to cause a difference? And that's where it all started. So this was a work published by Dr. Khanna is in the audience. He used to be my, I think, graduate student or postdoc at the time. And the editor asked me, Dr. Sen, you're saying it's 100 nanomolar. Can you tell precisely what's the cytosolic concentration of tocotrienol required to rescue these neurons? So what we did is we went into single-cell injection systems, and here you see one tagged in red, neuron that has been injected, the other is not injected. And in this case, once you now expose these cells to glutamate, every other cell is dead. The only one that is injected is alive. Okay? So now the question is, then we went ahead and started doing cell volume calculations, and then we reported, so when they pushed back at me at nanomolar, in this paper we reported it is actually attomolar, okay? 10 to the power minus 18, 10 to the power minus 18, right? Almost approaches like homeopathy doses, right? So it's quite striking. You cannot reproduce this with tocopherol. Not only can you not reproduce this with tocopherol, we just reported, I think last year or the year before, I have the paper here, that tocopherol does exactly the opposite. The opposite, okay? We just reported in FASEP Journal, and it got quite some good attention. I'll come to that study shortly. So we studied the first paper in stroke in 2005, and we reported that tocotrienol supplementation, you can rescue the brain at the risk of stroke, and this is the paper I was talking about. See, when you have laboratory animals, for those of you who work in the laboratory with mice or rat or anything like that, these animals have a lot of vitamin E in their chow. When you give them a lot of vitamin E in their chow, they appear shiny, they appear healthy, and people are happy. The bad news is that they have a lot of vitamin E in their chow, nothing to do with what a human has, okay? Now, we took those animals, and we thought the intent of the study was to take this TTP deficient animal, TTP, tocopherol transfer protein deficient animals, and if you now take these animals, you take away the ability of vitamin E transport. So even though they have vitamin E in their diet, the tissue will not get vitamin E. So in that case, what happens is that you achieve a vitamin E deficient state. So here you see the situation where you have the TTP knockout, and then two groups came from Japan and San Francisco. They came up with the TTP knockout animal. And when they came up with the TTP knockout animal, sure enough, they observed that these animals cannot breed. Tocos ferolis, loss of fertility. That's how it was named. So when you don't have it, they don't breed. So these animals did not breed. We took the animals both from Japan and San Francisco, give them tocotrienol, and they bred. And we reported that. So you could, and by the way, there are humans that have TTP deficiency, and they cannot breed, and they have neurological disorders. There are actually humans that have such genetic deficiency. So here, the point being that you could restore those deficiencies caused by TTP deficiency in both these mice that originated from Japan and San Francisco. Now here what we saw was that in the case of mice that had this high tocopherol in their diet, that actually we demonstrated exaggerates stroke neuroinflammation and therefore stroke damage of the brain. As you know, immediately after stroke, so during stroke you have some injury, and that's not all of it. Most of the injury after stroke is after stroke, post-inflammatory. So you mount a significant neuroinflammation response, and beyond that, if that inflammation does not subside, so essentially when you do MRI, which is the clinical standard to assess damage to the brain after stroke, what you're actually looking is neuroinflammation. So we showed that high tocopherol actually exacerbates, as you see here, stroke damage, but when you have high tocotrienol, you rescue from stroke. So these are almost opposing actions. Quickly going forward, we then published this paper in the Proceedings of the National Academy of Science, demonstrating that you have this animal model, where instead of causing stroke in the brain of a large animal by opening up a cranial window, which causes head trauma, or removing the eyeball, which also causes head trauma, we came up with a system that was endovascular. We went in through the femoral with a catheter all the way, endovascular, and then lodged a coil in the mid-cerebral artery. And using that system, when we actually caused stroke, we found, and this is what we reported, that this is the PBO stands for placebo, and TE stands for tocotrienol. Looks like the video is not playing because we changed, but this should be already published, but the video is not playing. The point here being that we reported that the protection against stroke that we found in the large animal was far more than what we saw in the mouse. In the mouse, it was roughly about, something like 20-30%. In the dogs, it was almost 80% protection that we found. So that was very encouraging. Then, as we were doing these studies, a group in Malaysia, as you know, Malaysia is rich in palm oil. A group in Malaysia got in touch with me, and they started designing a study. So the senior author here, Kay Ewan, is a good friend, and he has a cohort in UK and a cohort in Malaysia, and they kept these cohorts for a number of years on tocotrienol supplements, and they were able to demonstrate, and this was published in Stroke, that over time, age-related decline of brain function and age-related increase in lesion of the white matter can be significantly checked in humans if you take tocotrienol. So that's a very encouraging piece of work. After that, when we were doing these large animal studies, we actually ended up doing a baboon, and then we did these dogs that you see here. When these animals were under the C-arm, we actually could do angiography very well. And it is that piece of evidence that led to the observation that tocotrienol, not tocopherol, can induce brain arteriogenesis. That's a very interesting observation. So here you see is an affected part of the brain. You see the resolution here. The way I can show you this is we actually perfuse the brain with a particular polymer or a resin, then we digest the brain around it, and you can see the vascular tree is very dense. And as you see to the bottom of your screen is the stroke-devastated area of the brain. And on these, you can actually start seeing these types of collaterals that you see to your right bottom, and based on that, we published a paper with the molecular mechanism of how specifically tocotrienol is capable of triggering arteriogenesis of the brain following ischemic injury. Okay? And that is the current grant that I have from the National Institutes of Health that got funded a few months ago. So over the next few years, you should expect a lot of development in this progress, in this direction. Finally, in the final part of my talk, of course, I've been talking about experimental procedures and findings. Now, what happens when somebody has stroke? When somebody has stroke, they're not only just taking tocotrienol, they're taking at least a dozen other pills as standard of care. So the question was, how would tocotrienol do in a setting when the patient is already taking all these other pills? So what we had to do is we just completed the study of 150 patients that already had a mini stroke. And as soon as they had a mini stroke, we enrolled them into our study because we know that in the next year, 1 year, the chances of having another stroke is 10%. In the next 3 years, the chances are 25%. So then we started monitoring them for incidence of stroke and also for safety. As you know, any clinical trial, when you start, efficacy is always at the end. In the beginning, it's safety. So we did a dose escalation study on these patients. And the study was called Nutrition, and this is for those of you who are interested. The study is listed on clinicaltrials.gov. It is a registered study in the US registry, so you can look at the design of the study. The findings of the study are all posted in the web. I will not belabor the point here. So as you see here, this is the entry in clinicaltrials.gov. And what we found was, so when you have stroke, of course, you complain about things, right? Oh, this is not working, that's not working. So when we found that the placebo group complained 33% of the time of something or the other to the physician, the group that was in low dose, which was 200 milligrams twice a day, which is 400 milligrams a day, 24%, and 800 milligram complained, 17%. Nothing has to be here. There's no cause and effect. Just overall, the fact that there was no larger complaint because they were taking this, that was one level of evidence. Also, we had 3 deaths, and we had 3 strokes in these 2 groups, and of course, 3 is a very small number. Depending, if we're talking about a clinical trial, but the size of the lesion in the placebo group were much larger than what you had in the control group. They already had stroke, very small score, and those in the placebo group, 1 died and 1 with the MRS of 3, and this was no death, and 2 with no detectable MRI lesion. So that's quite interesting. Next, as we were following up on these patients, we collected a lot of data on them. And one of the data set that we collected was platelet aggregation. So as you know, platelet aggregation is a significant risk factor, and therefore many of us that are on a high risk for stroke take aspirin every day. And in this case, aspirin is a big deal. Of course, people question how important it is. Some believe it more than the other, but the rule of the thumb is baby aspirin is recommended widely. Okay. Now, as we talk about baby aspirin, we then also now have Plavix, we have aspirin, and in this case of post-stroke care, it completely depends on their respective doctors as to what will be prescribed for them. And when we actually took a look at their incidence or at their platelet aggregation following either when they took aspirin alone or they took Plavix alone, and some patients actually were prescribed both aspirin and Plavix. So we tried to really crunch that data, and just to remind you, of these patients and among all of us, there are people that are Plavix resistant, there are people that are aspirin resistant. What we found was, if you look at the aspirin group, what we noticed was that you have about 12%, 12.3% of the people were resistant, and that number came down to about 10.5%. That was only a marginal, not significant. However, in the aspirin plus Plavix group, we found that it was 41.7%, and that number came down to 18.4% in the presence of tocotrienol. So that's a very interesting development, because recently there was a big New England Journal of Medicine study on a much lower sort of change than this. So if you can correct resistance to aspirin or Plavix, or resistance to a combination of both, that is considered desirable by the clinical community. As we tried to tease out exactly what pathway of aggregation is affected, we came to the conclusion that it is adenosine diphosphate. These are data not yet published. So adenosine diphosphate and collagen, not the arachidonic acid pathway. I'll come to that shortly. So ideally, so this is a figure not made by me. It is made by a consortium of stroke in North America, Canada, and USA included. So people talk about the cytoprotection alone is not important. Also, there has to be a perfusion, effect. There has to be inhibition of neuroinflammation, and there has to be prevention and treatment of complications. So far, at least the dozen-plus paper published from my laboratory has evidence from all four of these, pointing towards a quite compelling case that a phase 3 trial should be done. So the phase 2 trial is now completed. We have now found that tocotrienol is safe, and of course, we also have found this resistance story. So overall, everything seems to be well positioned for the phase 3 trial to start. Finally, in the last minute or so, tocotrienol deficient animals. So one of the big problems, there was a paper in 1997 by a group in Japan called Hosomi. They report that there's this protein called tocopherol transfer protein, and that protein has affinity that is about 1/7 for tocotrienol compared to that of tocopherol. So people thought, well, TTP does not carry tocotrienol, so it must not be important. So like I said, when TTP deficient animals were made, and these animals were going sick, and the animals were not breeding, you could correct all of it with tocotrienol, arguing that tocotrienol transport circumvents the TTP pathway and actually adopts other pathways to get to organs. Importantly, we were able to breed these animals with tocotrienol alone. The human study for that, we just completed a 140 human subject study. In this study, we actually took heart, after we fed people with tocotrienol for at least a year, we took their heart, a piece of the heart, liver, adipose. We even took 1 gram of the brain out of a live human. And we measured and we reported. And this paper is out now. So there is no question that tocotrienol taken orally gets into vital organs. So if you read some of the reviews a few years ago, the big criticism was tocotrienol may be no good because it doesn't get carried by TTP, therefore vital organs of the human will not have them. So we have debunked that, and therefore I think the stage is all set. I think as we discuss, we can talk about that more, but as we were doing that study, and a part of our patient base were patients that were waiting for liver transplantation. In liver transplantation, there is this biochemical index called MELD. So if MELD is low, then you are triaged. If MELD is high, then you are prioritized for liver transplantation. So what was happening was we were spending a lot of money buying tocotrienol pills or so and giving it to people, but nobody was giving us back their liver. So we got down with the liver transplant surgeons, and we came up with the observation that as this patient started taking tocotrienol, the MELD score started improving, and they started getting triaged. So that was the first, and we did not want to study liver. We were studying something else. We were studying tissue transport of tocotrienol. The main focus was in the brain, but we also wanted to know what's the liver, because the liver is such a central metabolic engine. So long story short, we came up with the observation like you see there, and you see over the years, we have been following this person, and the MELD score starts dropping, and this was, and when we then combined the data for all the patients, this turned out to be significant. I'll skip some of these slides because they're really more like background. So we reported that just by taking tocotrienol, when you're waiting for liver transplantation, chances are that you could buy time. Not everybody can afford a liver transplantation. Okay, so if somebody can get a few more years into their life, that's already good. And if we could really understand how that is happening, then we could take that outcome to a much more lucrative end. With that said, like I said, when you took all the patients together, we achieved statistical significance. So now we have started a trial. The trial is listed. It is ongoing. This is the clinicaltrials.gov. And if you put my name and you put tocotrienol, you should be able to find this out. And on the entire study design and current progress, every 3 months it needs to be updated. So we keep on updating it. You should be able to find what's going on there. Finally, as things were happening in that trial, I started talking with the US FDA. And very long story, very short, it's not very easy to get IND, an investigational new drug recognition for a herbal from the US FDA. But now tocotrienol has the first IND, as you see here to the screen. So that's the IND awarded to tocotrienol for NASH. So now clearly this FDA trial will continue. We will at some point be done with it. And I think this is a significant turning of the corner for tocotrienol in the lifespan of tocotrienol science. This is the first IND FDA trial on tocotrienol. We'll see how it goes. But currently, I'm also preparing for our FDA submission on stroke. And I have some other indications that we are interested in. If you're interested, we can discuss about that in the panel. Finally, I'm thankful to the Malaysian government, which is the MPOB, and Pemandu is from the Prime Minister's office for our Developed Malaysia. So those are the programs that fund us. HOVID is the company that provides us with the material. I'm thankful to the NIH, and I'm thankful to the American Heart Association. Thank you for your attention.
Thank you, sir. It was absolutely spellbound. We have no words. The way you have put forward and where we see the role of tocotrienol, which is coming up in a big way. And I think you made us the things much simpler. So I'm going to take the matter forward on this. Whatever the research and the implications, what you are doing, and we are going to see how it can be utilized in clinical practice. So we are going to have a panel discussion on clinical applications of tocotrienols. There will be little overlap, so I will like to skip certain things which sir has already covered, and I would like to cover up other things. The tocotrienols, it is popularly known as T3, so which is a known figure. Now, when you're in a conference, the conference usually is meant by the confusion of one man multiplied by the number present. We have a good number here. And a conference room is a place where everybody talks, nobody listens, and everybody disagrees later on. But today, the things are different because we have a galaxy of eminent panelists with us. So Dr. Chandan Sen, who has already been introduced, is over here. May I call upon our second panelist, Professor Dr. Subhashi Manchanda, a very renowned senior cardiologist from New Delhi. He has been at present senior consultant at Sir Gangaram Hospital. He is formerly professor and head department of cardiology at AIIMS, New Delhi. He has a professional teaching experience and research experience of almost 4.5 decades. He had more than 400 scientific papers, 50 chapters in standard medical books, authored 4 books. His special interest is preventive cardiology, though he is one of the first intervention cardiologists to went into the journey of angioplasty in the country like us in India. So that is, we feel proud that he is nurtured into now preventive cardiology. There are very few people who would go into it. He is a recipient of Padma Shri by the President of India. He has a Lifetime Achievement Award by the Cardiological Society of India. He has original research work in the field of high altitude problem and lifestyle modification. He is editor-in-chief of Journal of Preventive Cardiology. and so on and so forth. So I welcome you, sir, for this panel discussion. May I also welcome Dr. Ronen Roy, an eminent senior consultant orthopedic and joint replacement surgeon from Fortis Hospital, Kolkata. He is the Vice President of Indian Arthroplasty Association, Vice President of Indian Executive Committee, Hip and Knee Surgery. He is the President of West Bengal Arthroplasty Society, and he has served as a full-time lecturer in orthopedics and trauma at the University of Wales, Cardiff. Welcome you, sir. I also welcome my another good friend, Dr. Somik Goswami, of course, an endocrinologist from the city of Kolkata itself. He is clinical tutor and in charge of research lab, Department of Endocrinology, NRS Medical College. He is associate editor of Indian Journal of Endocrinology and Metabolism, and he is also joint secretary, Diabetic Association of India. Welcome you. So friends, this first we will see how the tocotrienol can be taken up in clinical practice, and of course we are going to, as I mentioned, that this is going to be a live webinar. We will have definitely questions coming up from various places. Now, after knowing this, what we realize, Isaac Newton's statement, what he said is, what we know is a drop, what we don't know is an ocean. And Dr. Chandan Sen is really digging out the ocean, and we will know over a period of time what this is really going to do to us. So let's start these questions. So Dr. Sen, what earlier the term tocopherol was used synonymously for vitamin E, it should be, I agree that it should be totally be given up. Either you use the word tocopherol or tocotrienol rather than using the word vitamin E, because it doesn't justify. So you totally agree on that?
So, see, let's go back to the history on how vitamins were named. Vitamins were named back those days on correction of deficiency symptoms. I just showed you data that deficiencies caused by even tocopherol, such as tocopherol loss of fertility, can be restored. Unless somebody can show. So there is overlap of function, and then there is differentiated function. So clearly, as has been published in over, I would say, 50 papers plus, the vitamin E family consists of both tocopherols and tocotrienols. But as it comes to a product, I think it's very important that people specify, is it tocopherol, is it tocotrienol? Even if it is tocopherol, tocotrienol, alpha, beta, gamma, delta, and very importantly, are they natural or synthetic? So I agree with you that it is important to specify what form of vitamin E is in the product.
Correct. So here the message is, tocopherol and tocotrienol is not synonymous with vitamin E. You need to clarify what it is. And of course, so you just briefly mentioned the difference between tocopherol and tocotrienols, and which obviously there are not only just a structural difference, but in terms of applicability, the usage wise, there is a significant difference. So it is wherever the place of tocopherols, to tocotrienol also has a place, but on and above it is a distincting role also. And as sir has rightly mentioned that 95% of studies were on tocopherols, and you had a very limited study which was coming up on tocotrienol. So that was the thing which is there. And I just came across one data, so just to share with you the permission of Dr. Sen, that why this tocotrienol is super vitamin E, because under important conditions for antioxidant defense, what has been found, it is a 40 to 60 times higher antioxidant activity against lipid peroxidation by free radicals. It provides 6.5 times better protection of cytochrome P450 enzyme system. It decreases oncogene expression. It increases the level of tumor suppressors. So it has an anti-proliferative, apoptotic, antioxidant and anti-angiogenic effect, which is not seen with tocopherol. And that is where it has a huge, wide application in clinical setting as opposed to tocopherol. So now let's go to the clinical case scenarios. I'm giving you, because as a clinician, you all are going to come across the things, and let's see where do we face such situation where it can be implicated. So this is a real life scenarios where we come across in day-to-day practice. A 52-year-old male undergoes a executive health checkup. This is somehow a fashion in India. The company provides, they go for a health checkup. And, accidentally, he has nothing, no issues. He comes with the fine, with the report, total cholesterol of 296 milligram per DL, LDL of 196 milligram per DL. Rest, everything, biochemistry is normal. He goes to Dr. Manchinda, and sir, obviously, I am sure he won't agree with. He is going to first advocate aggressive lifestyle modification, not just diet, exercise, but de-stress, and on and above, he's looking at his value, would put him on. So he was put on atorvastatin 20 milligram daily. So which is a routine case any one of us clinician would do. Now 6 weeks later, he developed severe myalgia, leg cramps, body ache, and fatigue. He was not knowing now, and Dr. Roy was also a good friend. So he thought, I have got some muscle ache, leg cramps, and let me go to my friend, Dr. Roy. So he goes to an orthopedic surgeon, and obviously he goes into the history, get the CPK total, which was normal. So I will ask Dr. Roy, or rather I would say Dr. Roy can summarize and give. Now this was just one subset, but a patient coming to you with any other muscle cramps, with or without statin. With statin, I know your therapy would be different, but without statin, sir, what will be the things which you look for, or where do you place the role of tocotrienol, sir?
I'd like to talk about the role of vitamin E and tocotrienols basically in musculoskeletal disorders, because I gather there's nothing else for me to talk about. So basically what we realize is that muscle cramps form a very important part of orthopedic practice. And usually we find that, as Dr. Sen outlined, we often try muscle relaxants, but these are self-limiting and we can't use them for a prolonged period of time. So things like thiacolchicoside or carisoprodol, we tend to use for relatively short duration of time. Whereas the vitamin E's, that's the tocopherols and the tocotrienols, are relatively benign, and we can use them for much prolonged periods. And there have been a couple of studies, in fact, in dialysis patients where it's been seen that they're as effective as quinine and far safer than quinine as far as controlling cramps are concerned. So it's definitely a very useful drug in clinical practice, and we tend to use it extensively. Another common problem that general physicians and orthopedic surgeons face is fibromyalgia, where you get unexplained pain, and often along with the other forms of treatment that are available, addition of the vitamin D often tends to not only reduce the symptoms, I won't say alleviate them completely, but they definitely have an adjuvant effect. So in addition, say, to duloxetine or all the other modalities, acupressure, acupuncture, physiotherapy, and anti-inflammatories as required, counseling, vitamin E's also tend to have a significant effect. The other thing, as Dr. Sen was saying, is in neuroprotection, is in orthopedics, the other problem that you often get is back pain with pain down the legs in elderly patients in the form of claudication. And this is usually a result of neurogenic claudication, which is quite rampant in our country, as opposed to Burgess disease or vascular claudication. And again, where we tend to use gabapentin or gabanuron and medication like that. But along with that, if we give an addition of vitamin E, we find that there is definitely an additive effect. So it's common scenarios like these that orthopedic medicine, so to speak, depends heavily on vitamin E and its various forms. I mean, I think I'd leave it to Dr. Sen to probably elucidate which is the more protective one. And I think tocotrienols definitely need more study in these respects. And as he said, that it's time that we go in for properly designed trials so that we can answer these questions. But as clinicians who deal with a significant number of patients, I think that there is a significant role to be played by these molecules which we haven't really explored so far.
So that means you have various types of muscle aches and pains, muscle cramps, and of course neurogenic claudication pain and fibromyalgia, where it can be used, and sir has seen the results out of that. You've seen the patient, sir. So that's a good thing. Now, of course, here in this case, our patient was on statin, so he rightly said that, first you go and meet Dr. Manchinda only, because you have been prescribed statins. So, sir, what will be the next step? You have a choice over here. First is stop statin. Second, reduce the dose of atorvastatin. Third, change over to another statin. Or fourth, reassure and continue the same. His CPK total is normal.
Yeah, from the history, it looks that he is having a side effect of atorvastatin. But I must say the atorvastatin side effects or any statin side effects are exaggerated. There's a paper, you see, when they take atorvastatin, they go to the Google and they see leg pains are very common there. Even their friends tell them, you're taking some drugs which will cause leg pain. So the recent study which shows that many of these patients were just by suggestion they were told. In this patient, the CPK is normal, so it doesn't look to be related. But I think I would still stop the atorvastatin to be sure that it is related to that and start it again. This is a statin intolerant patient. His LDL is 196, which is very high. It looks like a familiar hypercholesterolemia. He will need a statin. So there are several strategies. One of the strategies, you start with a different type of statin in a smaller dose and add another drug. And here I will like to add tocotrienols. Tocotrienols have a double effect. They are hypocholesteremic as well as they look after the muscle cramps also, whatever is the cause. It doesn't appear to be that, and slowly build it up. So there are different strategies which are there for statin intolerant patient. He is not really a statin intolerant because his CPK is normal. Maybe he will also need a lot of psychotherapy. Initially, you have to stop it, of course.
Okay. Now, I would add on to this, now subsequently, the follow-up. What happened? The patient was advised to reduce the dose of atorvastatin to 10 milligram daily. Again, no difference in symptoms. Finally, he was put on 5 milligram atorvastatin, but with no relief. So, like any dose, he was not tolerating. Obviously, now the question is, what was your next step? Stop statin, reassure, continue same, change over to another statin, or replace with. And sir has already given the answer to that. Obviously, you have an answer over here where he is really not tolerating. And I'm sure all of us come across a small subset of patients who are not tolerating statins, so where we can replace with tocotrienols. Friends, a word of caution. That doesn't mean tocotrienol is there to replace each and every statin. Statins are a wonderful drug, no questions about it. Sir would agree with that. But we are talking on a small subset of patients who are really intolerant to statins, where we have something to offer it. And
I'd just like to add a word here.
Right, sir.
You see the guidelines, if you see statin guidelines, they say unless the LDL is more than 190, do not start in a low-risk patient.
Correct.
And we get a large number of patients whose LDL is 150, 140. They have no other risk factors.
So we are coming to that.
Yeah, okay.
That is, we are coming.
This
So
is
here,
these are the
clear-cut
cases
indication.
where tocotrienols are absolutely indicated.
Yes.
And so many cardioprotective effects are also there.
Absolutely.
Okay.
So, sir, what is the role of T3 in this management of dyslipidemia? The mechanism, how does you think would be beneficial acting in this? So, is it the same as HMG coenzyme reductase inhibitor? Because that is what has been said.
No, there are two mechanisms. One is the partial HLD coenzyme inducted. There's another pathway which does not involve this, and therefore the side effects are much less. And therefore you can add it up with statins also. There are studies to show that if you add it with statins, the effects are exaggerated.
Correct.
There are some supplements which act like HMD3 coenzyme. They may not really decrease the side effect, but this does. This has two mechanisms which are different.
Fantastic. Sir has rightly said, and in fact, I came across one of the nice schematic diagrammatic representation where tocotrienol, like if you really see, the tocotrienol inhibits the conversion of farnesol to farnesyl, which has got a bionegative effect and HMG reductase. Now, if you see the biosynthesis of cholesterol from farnesol, one pathway is farnesyl and another pathway is geranyl. So you have a sparing of coenzyme Q10 and protein. So which is the deficiency? Dr. Goswami would agree that so often we see this as a common effect, and this could be one of the possible mechanisms by which the side effects which are seen with statins are not seen. though it is a HMG coenzyme reductase inhibitor. So my question is, how will you compare now vis-a-vis statins versus tocotrienols?
Just to add on, with regard to dyslipidemia, T3 has a protective effect in terms of reducing oxidation of LDL as well.
Okay.
So it has a partial HMG-CoA reductase inhibitory activity, post-transcriptional mechanism, and a mechanism by which it reduces oxidized LDL as well. I think Dr. Sen has evidence on that. So it's a two-way mechanism by which it benefits people with dyslipidemia. And as you said, rightly said, a decrease in coenzyme Q is one of the mechanisms of statin intolerance.
Correct.
So if you use it as an adjunct with statin in patients who are intolerant, instead of stopping it at the first instance, a portion of them might recover from this intolerance as well,
Okay.
with additional LDL lowering efficacy.
Dr. Roy, have you used the coenzyme Q10 along with vitamin E or in tocotrienol in such patients who come presents with the leg cramps, and what is your experience, sir?
Well, I'm a simple orthopedic surgeon.
Yeah.
I mean,
sometimes patients
honestly
come
speaking, we don't use coenzyme Q very often in orthopedics because, honestly speaking, I think the cost is prohibitive,
High.
and especially for prolonged usage, which is often required for these musculoskeletal problems, patients really would prefer a simple paracetamol, which is far more affordable.
Okay, so that means the side effects is an issue which is there, and sometimes we get. That reminds me a nice quote from Professor Dr. William Osler, who is considered as the father of modern medicine, and he had said one of the first duties of the physician is to educate the masses not to take medicine. And I can see Dr. Manchanda is really following his trend. First is not to take medicine. And you start wondering, he's the father of modern medicine. And why does he say so? But he has explained very nicely in the next statement. He says the person who takes medicine must recover twice. Once from the disease and once from the medicine. Which is so much true today, be it your anti-diabetic, anti-anginal, anti-hypertensive or lipid-lowering drugs. Each and every drug has its own side effects. So we need to use it carefully and be watchful about this. And as sir has rightly said, there are various trials about the tocotrienol reducing the cholesterol levels, which we have seen and which overall reduces the risk factors. Rather, there is one study which is, data which has shown that the gamma and the delta isomers enhance the LDL lowering effects of statins by an additional 50%. And sir has rightly said that you have a data that using to combine, or if you have a patient who are intolerant with a higher dose, you can give a low dose and add tocotrienol, so we'll have a still beneficial effect on that. So fantastic, sir. What we will do is, okay, now this is Dr. Goswami, another gentleman coming to you, 48-year-old businessman, asymptomatic, goes for another health checkups, no habits, weight 88 kg, BMI of 31, BP of 148/92, total cholesterol 242, HDL 38, LDL of 146, triglyceride 226, sonography found to have a grade 2 fatty liver. And he is absolutely fine, So as sir was discussing with me at the lunchtime, that he goes as a human being, comes out as a patient, and he is labeled that you have got a dyslipidemia, you have got a non-alcoholic fatty liver disease. His friend says, you didn't drink, that's why you got a liver problem. So, these are the various things they will come out. So, what do you see? He is a typical metabolic syndrome type personality patient, though he doesn't have any problem.
Exactly.
So obviously, now what are your options in this patient? Only lifestyle modification, you will add statin, or you will give fibrate because triglyceride also is a bit on higher side, or of course I know Dr. Manchanda was going to be there, so lifestyle modification plus everything. So what do you feel?
So again, as you said, a typical metabolic syndrome phenotype, very common in Asians, Indians particularly. And as Dr. Manchanda says, rightly, he's not a patient at this point of time.
Correct.
But he is a person who is at an increased risk of becoming a patient in the future. Increased risk of developing cardiovascular disease, diabetes, and so on and so forth. But the thing is, in patients like these, the first thing that we do is lifestyle modification. First, second, third, lifestyle modification. But again, looking at things from a practical point of view, it's very difficult to implement lifestyle modification. So out of 100 patients, possibly only 30, 40 at the most, if you're very lucky, will go on to follow lifestyle advice particularly regularly. In the big proportion who does not follow lifestyle advice, you need to go for adjunctive therapy. And as we discussed earlier, since there's evidence of tocotrienol in terms of reducing dyslipidemia, there's evidence in non-alcoholic steatohepatitis. I won't say mere simple steatosis, but if you have steatohepatitis with elevated enzymes, there's evidence. Interestingly, there's also upcoming evidence that it could be an anti-obesity agent as well, because it has certain anti-angiogenic effects. And increased angiogenesis drives increased fat accumulation in the body. So we need more evidence on that ground, and since we know obesity is the root cause, visceral obesity is the root cause of A, B, C, D manifestations and diseases related to metabolic syndrome, we need data coming up with regard to obesity as well. So overall, lifestyle modification first, tocotrienol as an adjunct later on, if necessary.
So now, as you said, and as Dr. Chandan Sen has already said, now we are getting a data of role of tocotrienol is non-alcoholic fatty liver disease or NASH, which will be helpful. So obviously you have got a lifestyle modification with tocotrienol as one of the choice will be there. One quick question, Dr. Goswami, like now this is a next case, 62-year-old male, diabetic since 8 years, hypertensive since 17 years, had an anterior wall MI 3 years back and was treated by Dr. Manchanda team, had done PAMI at that point of time. And he is on a standard line of treatment, antiplatelets, statins, beta blockers, ARBs. Now he developed acute hepatitis with jaundice. On investigation, his SGOT is 2,356, SGPT 2,684, bilirubin of 3.8, predominantly direct hyperbilirubinemia. So I'm sure you are not thinking in terms of statin-induced. And obviously you got the markers done, and his anti-hepatitis E virus, IgM, turned out to be positive. So he's an acute viral hepatitis E with underlying background of diabetes, hypertension, ischemic heart disease, who had undergone angioplasty. So now he is on a high dose of statins. What are you going to do? Continue statin, reduce the statin dose to half, stop statin totally, or change over to something?
Now, that's a very difficult scenario, but
that is why I'm putting you to you.
But
and
I think
sir will add to that.
this is a situation of acute viral hepatitis.
Yes.
I would be more interested in looking at the liver function parameters as well, like say INR or the albumin levels. So acute viral hepatitis is expected to resolve in say 4, 5, 6 weeks at the most.
Correct.
So during this period of time, if there is some sort of alteration in liver function, I'm not talking of the liver function test, I'm talking of INR, albumin, and so on and so forth. Stopping a statin would be a judicious choice. In that case, again, an adjunctive role of agent like T3 comes into the picture. I think Dr. Manchanda can enlighten us more about a difficult situation like this.
Sir had done the plasty. Sir, his team has done the primary angioplasty. So.
This patient has several problems. There's acute liver injury. Yeah. So you must stop the statins.
Yes, that's the first
statins,
message.
There is no question about it.
Correct.
This patient must also be on antiplatelets. Dual antiplatelets, and you have to be careful about that. You have to find out the INR and the bleeding time, etc. To be careful about that. Yes, there are no guidelines, but to cover up with something, because you want to give him a little antiplatelet, you want to give him some anti-diabetic and all. In such cases, I have used it. I will use it T3 because it has all the effects that we want. It is some antiplatelet effect, anti-thrombotic effect. It is not harmful to the liver, etc. It can lower the cholesterol, etc., and so on. We do not know, it is not recommended, but I think the recommendations are very little for this. Correct. One has to use common sense, and there could be several situations that you could use. I would like to use in this.
So, it's like something better than nothing. You have some agent which has a protective action and where you can't give a hepatotoxic agent. So obviously you will be changing. Due to paucity of time, I would not take one more case. So as sir was rightly mentioning, cardioprotective actions by predominantly what is got due to decreasing oxidative stress, by inhibiting plaque progression, and of course correction of hyperlipidemia, which all three attributes to the cardioprotective action. And Dr. Chandan has rightly showed that what a beneficial effect which we have got in another vascular bed, cerebrovascular events, which is fantastical. In fact, I had seen his, unfortunately the video didn't run over here, but I had seen how beautifully in a three-dimensional way it has been shown. I remember, sir, which you had shown the damage which is caused, in the placebo versus the tocotrienol arm, the changes which are there significantly. So we know the reduces the oxidative stress, but always the question comes, there is an antioxidant. We as a clinician feels, anybody talks of antioxidant efficacy. And one thing, what data we have got, there has been a definitely objective evidence that how do you define an antioxidant property. There is a unit called as ORSE value, which is oxygen radical absorbance capacity, and which is highest with tocotrienols. So this has been unit of antioxidant activity by any substance or nutraceutical compound, and which has been given by NIH. So there is a data that it has a potent antioxidant activity. So role of T3 in other vascular beds, sir has already shown about the neuroprotection, and I would not go into the detail. Now let me ask Dr. Goswami, is there a role of T3 in diabetes management?
Again, just to cut a long story short, 1 or 2 points important. One, there is data to show that it improves insulin sensitivity, reduces insulin resistance, but that's rodent data. We need human data as well. There's interesting data to show that it could ameliorate nephropathy and neuropathy. And there's data to show that it reduces levels of advanced glycosylation end products, reduces malondialdehyde, and we know that these AGE, malondialdehyde, these all contribute to the microvascular complications. So regarding microvascular complications, we have interesting data. Regarding improvement of insulin resistance, we have data. Now most of this is rodent data, animal data. We need more data in humans, but the animal data is quite exciting. So to cut a long story short, this is what we have.
Okay.
And I think Dr. Sen will supplement something.
I think one of the mechanistic underpinnings that cut across all these indications would be the anti-inflammatory pathway, because that would, compounded with what he just said, changes the scenario altogether.
Okay, so that means we are seeing that, of course, and there is some data about vitamin E supplementation has been shown to decrease the HbA1c in lipid peroxidation level even in type 1 diabetic subjects. So more and more data is coming, so it will be correct. Absolutely. And of course, the lipid peroxidation pathway of getting affected, you are going to have a beneficial effect. So we are going to see more as a supplements in all diabetic subjects, and in even a role in type 1 diabetics also. So it has overall, tocotrienols we know has got a significant benefits in metabolic syndrome by improving the glucose hemostasis, being atheroprotective, causing plaque regression, reducing triglyceride, improving HDL, lowering LDL. So overall, it is a good metabolic syndrome protecting agent. Okay, now I had already asked this question to Dr. Rao. But now there are some data which is coming up about osteoporosis. So probably we will have to see in future the role
that's right. I mean, it's supposed to reduce osteoclastic activity to some extent, probably again through the HMG-CoA reductase inhibition pathway. And we again need to do some proper studies to see how effective it is. But usually when we prescribe it to the elderly, as you can see, it's got multiple benefits. I mean, it's not just one system.
Correct.
You're affecting multiple systems. And so if a physician prescribes it, an orthopedic surgeon is happy. If an orthopedic surgeon prescribes it, the cardiologist is happy. So I mean, I think we're a happy bunch if this is actually prescribed.
I fully agree.
I can call it a holistic molecule. You see, it's very promising. There's no molecule that I know which is so promising. But as he said, we need large randomized controlled trials. Only then it will be accepted. But it appears very, very promising. You have to use it at your discretion. But till the studies are there, I think we can't
Correct.
recommend all the time.
in your practice, what are the places where you really use it? So that is what we would like to know.
You see, one of the situations, because of the guidelines, we are, as I said, the guidelines say don't treat LDL less than 190 if there are no risk factors. Now, there are a large number of patients who have a cholesterol, LDL is 130, 140. According to the guidelines, we should
Like
not.
one of our
Yes,
patient, huh?
One of your patients, but
Huh.
there are no other risk factors. In such patients, I like to use it.
Okay.
Secondly, I like to use who have multiple risk factors. For example, you do a medical checkup, you find intimal medial thickness, everything else is fine. What do? There are no recommendation really for secondary prevention. In these cases, I could use. Thirdly, those who are intolerant to these statins, there are a large number of patients and all, you reduce
Like
the
we
dose,
said.
start slowly, and you add it up. I have found definite use in this. And thirdly, any high-risk patient who is going to develop a metabolic syndrome, for example, who's going to develop diabetes and all that thing, has a family history, etc. I like to use a drug, I call it a holistic drug, because it affects almost all the things, atherosclerosis from the word go till the end, it does help. For example, as he showed foam cells, etc., the start of atherosclerosis stopped, and then it can reverse atherosclerosis. That is very important, and it is anti-inflammatory and anti-oxidative stress. So these are the causes of
Correct.
atherosclerosis. So I would like to use this, but as I said, we need more
Data for it.
randomized controlled trial.
Analysis.
But it appears very, very promising. Even today, I said, in these conditions, I will definitely use them.
I think that term what you used, a holistic drug, sounds really good, that, you had a broader spectrum across which this can be used. So, Dr. Goswami, what do you think? What is the dosage recommendation of T3 in clinical settings?
The dose recommendations range from 30 to 200 milligrams per day. And just to add on to what Dr. Manchanda said, another exciting area of use is non-alcoholic steatohepatitis with early fibrosis. So if you have non-alcoholic steatohepatitis where the enzymes are elevated, you give tocotrienols 60 milligram to 200 milligrams per day. You review the ALT levels after 6 months. If you get a benefit, you continue. If you don't get a benefit, in that case, you can discontinue. So NASH is an additional area of use. So as rightly said, the dosage is 30 to 200 milligrams, but most of the studies have shown higher the dosage used, better the benefits.
Okay, and how safe is the tocotrienol in clinical usage? That has been questions now already started coming up. And you think how long the T3 can be given without any adverse events?
If you look at the evidence, there are studies ranging up to 2 years, randomized controlled trials ranging up to 2 years, which have looked at T3 administration and have found it to be safe. And as we know, it's as the US FDA brackets it as generally recommended as safe, GRAS. So it's safe, to say the least.
Correct. It has been rather labeled as a GRAS, what is called as generally recognized as safe status notification has been given to this palm oil derived tocotrienol. This was on April 23rd, 2010. This GRAS notification has come to this molecule. So which is a fantastic thing, though it is a fat soluble vitamin, but it has still come in the category of GRAS, which is really a big achievement, because today that is what is really required. Whatever you are using it, it should be safe for your patients when you are using it. So we are seeing a lot of things, and as I like the word about the holistic approach, we know the right words from Albert Einstein, who said that not everything that counts can be counted, and not everything that can be counted counts. So which is so much true over here. So I think what is the take-home message that, what we see, the indications of tocotrienol in clinical practice are huge. I think probably across the spectrum, right from metabolic syndrome, cardiovascular disease, dyslipidemia, Alzheimer's disease. Dr. Sen has really shown that now there are the trials which are going to start about it. Malignancies, now we have not touched upon because it's there. Dr. Sen would agree because there is a huge data. There are another research team who is really working on it. We have got colorectal cancer, CA prostate, CA breast, CA lung, CA pancreas. Of course, obesity which has been already touched upon, osteoporosis, NAFLD, and of course, Dr. Roy has already touched upon nocturnal leg cramps, dialysis cramp, restless leg syndrome, claudication, premenstrual symptoms. So on and so forth, a real holistic vitamin, which you would really put it that way. And it has so much pharmacodynamic advantages, which we have seen and has discussed about. probably the awareness which was lacking. So we need to create that awareness. In fact, there is one very nice editorial. I mean, it was in the Indian Practitioner, Jan 2012. And if you get a chance, do read it. It's a 3-page editorial, lovely written. It is considered as tocotrienols, a vasculoprotectant of the 21st century. A beautiful article which is there. And you will realize we were not having the concept. Because when we all studied, there was nothing. There was only tocopherol, which was there. You know, all the textbooks of pharmacology, you know, where Martindale, Goodman and Gilman, these are all supposed to be the Bibles of pharmacology, which was also only mentioning tocopherol, and it was not mentioned about tocotrienol. I would end with a nice Chinese proverb. I don't know how to read Chinese, if anyone knows, but the meaning of it, that superior doctors prevent the disease, mediocre doctors treat the disease before evident, inferior doctors treat the full-blown disease, and we Indians, whether you are practicing in India or in US, Indians, they are far superior than our counterparts in the West, and we should be proactive, go for a preventive one, and I'm so happy Dr. Manchanda is here, who is being an interventional cardiologist, is strongly recommending for going for preventive cardiology. So, my presentation is over. Now we will quickly have few minutes to take questions. How much minutes can we have? 5-10 minutes? Okay, fine. So we are proud that we are in India with API, we are discussing this. So really, it is really a matter of proud for all of us. So first we take the questions from the floor, and then I will take few questions which we have come from our other sides. Yes, madam. Yes. Can we have the mic over there quickly? Huh?
Very, very favorite and interesting topic for me, because I'm also a preventive doctor, but I'm at the other end of the spectrum. I take care of the shrimpodes, 0 to 19 years. My vested interest is on the neurogenesis, neuroplasticity, resilience, and how to prevent the nerve injury from toxic stress to just about everything. I see a major role from NICU graduates in the tocotrienols. I'm not very much aware of this. Has there been any studies that have been done, or are you working on that? Because it is the apoptosis we are trying to prevent, and I try to prevent 0 to 3 years from environmental toxicity, experiential neuroapoptosis by not using the pathways. And that little slide attracted me, where tocotrienol was given into the cell, and there were dendritic arborization, which creates pathways that are very strong to the frontal lobe. Now we are seeing a lot of later adolescents, neurodegenerative disorders from Zulon study, from electronics being used, disengaging electronics, causing frontal lobe attrition and promoting the addiction centers in less sensitivity. So I want to know the role of this tricotrienol and the dosing in the pediatric age group, NICU graduates, 0 to 3 to prevent apoptosis, and in ADHD patients where there is neurodegeneration, so on and so forth, and also with electronics.
Dr. Sen, I think you'll be the right person.
Yes, and I wish I could answer you in a more enlightening manner, but clearly the pediatric evidence is almost non-existent. But you make a very good point, and I think the rationale is very clear, and I hope new studies are motivated by current data. But right now, pediatric applications clearly, there's nothing almost. On the microphone.
So the case number 1 which was presented, just in a scenario when somebody get really bad lipid profile, cholesterol is high, triglycerides are high, but when they go for their angiography is clean. So, but doctors are saying you take statin. So what should we do in that scenario?
Dr. Manchanda.
Yeah, that's called primary prevention. You see, this patient had a very high, I hope this is after lifestyle, this is very high, 196.
Yeah.
Such patients should be really screened for familial hypercholesterolemia. It's a very common disease, completely ignored. We have done a lot of work on that. Anyhow, this patient will need statin if it is 196. And because this is primary prevention, superior doctors treat the disease before it appears. So the disease will appear, and because the familial is a very malignant disease. And statins are the best. If he cannot tolerate statins, there are so many methods. You stop it, start with a small dose, give once a week, or change the brand of statins, etc. Or you start the new PCSK9 inhibitor. They are available in our country. So these are some of the methods and all. But I think it is possible to give statins, but in a smaller dose, and with that, this will be ideal to add. Suppose the patient tolerates a smaller dose, then you add up this tocotrienol. That will be the ideal situation. That will prevent his muscle cramps, etc. also, and small dose generally is well tolerated.
Okay, now we'll go to the first, because since we have a webcast, the question coming from Agra, we'll take it later if we have time. One question from Agra, any trial on parenteral tocotrienol? Dr. Sen?
No trial.
No trial.
No
Okay,
trial.
and any data on beneficial effect in dilated cardiomyopathy?
No data available on this.
Okay, fine. Now, another question from Patna. Any contraindication to the tocotrienol in any individual? Any contraindications?
I think this is a very important question, perhaps more important than where it works, where it doesn't work, because the first thing is we cannot harm before we help somebody. Now, you mentioned about GRAS. GRAS is usually decided based on a healthy individual.
Correct.
Our experience with people, I showed you the cohort that had mini stroke, 150 of them, and then we followed them for 3 years, and at a point where they had a second stroke, some of them died, some of them didn't. In a vulnerable population like that, we had no signs of any side effects, because we were under very close watch of the regulatory bodies, and there was zero side effect. And that was most encouraging. So I think that should answer the question.
Okay. And the same, one question from Agra is about safety in children and pregnant lady.
Safety in children and pregnant lady. Now, there is no human study on that. There are extreme high doses. So this is just a quick escape into biology. There's something called teratogenic effect of a chemical. So those studies have been done where extreme high concentrations have been given to pregnant animals and safe birth has been recorded. So usually you don't do such extreme studies in humans, but I am not aware of any other pregnancy-related.
Study in obese children with NAFLD, which was titled TONIC, T-O-N-I-C, which did not show significant benefit, but there wasn't any harm either. It's not recommended for use in children. But
Correct.
the small study, there was no harm, no benefit.
Correct. Okay, now we come back to Kolkata. Yes, now gentlemen, yes. I think we traveled Agra,
thank you very much, Dr. Mehta, for wonderfully moderating the whole event.
Thank you.
It's very wonderful and very nice, panel discussion. And I would actually, my first question is actually just being answered by Professor Sen, that whether any contraindication of the tocotrienol. And I think we just recall the CARET study, because in the reperfusion injury, there is the beta carotenoids was prevented. I mean, that trial was, prevented. Stop. Right, that's right. So I think that is there. And so that was my first question. And just I want to share one thing that, in fact, we have done some basic studies with our animal models. And we have already published it with ferulic acid and atorvastatin in combination study. And we have found, just to, I want to share that, as you mentioned, that there was whether any inflammatory developments were prevented by the statins. And in fact, it was done by this combination therapy. So I think there is a positive effect with the ferulic acid, but I am not sure about this tocotrienol though. And regarding the other, yes. So that is one thing I want to share. And obviously the ferulic acid, I would like to know that whether any other than the tocotrienol, any other derivative of the tocotrienol, I mean, which could be, can compete or can be better alternative of the tocotrienol.
Dr. Sen.
So there are many derivatives. You know, I argued against, in my lecture, I argued against the use of synthetic variations. But if you take a pentamethylchromanol, PMC, it's very strong antioxidant effect. It's without the tail. So you saw tocopherol with a saturated tail, you saw tocotrienol with an unsaturated tail. If you chop the tail, then you get PMC. And that has extreme high antioxidant capacity. But as it relates to the body can discriminate between the natural and the synthetic version. So in general, I wouldn't recommend going into the synthetic side. But there are derivatives.
Okay. Yes, doctor.
Thank you. I have a quick question for Dr. Sen. You mentioned that you're entering phase 3 trial, right? So it's not approved by US FDA, right? Is tocotrienol, and my second question is, this is a fat-soluble molecule, right? So do you have any data on any tissue accumulation?
Second question, answering first. So tissue accumulation data is published. So tissue uptake, all vital organs get them. Yes, it is fat soluble. Yes, it is. It forms a hook-like structure and it dangles with the membrane. So there is compartmentalization of the tissue. All of that is published and well known. Coming back to your question, IND is not given. So IND is given as an investigational new drug. That is when FDA thinks that there is enough reason to test a molecule as a drug. So not very few herbals, very, very few herbals qualify even to get an IND. After you get an IND, you do then trials at the phase 1, phase 2, phase 3, and in many cases a phase 4. And then even for a phase 4, they have to be reproduced before they come into standard practice. So I think the confusion here, perhaps in your mind, is IND is not given at the end of a phase 3 trial. FDA approves something that has the likelihood of being a drug, and therefore now FDA prescribes a definite pathway that now needs to be followed, and the results of that will then decide whether it is successful or not.
Let me clarify the question a little more. I practice in the United States. I practice in both countries, actually. So, can we prescribe tocotrienol in the United States? I'm from Seattle.
Yeah, tocotrienol is over the counter in the U.S.
But that's over the counter.
Over the counter, yeah.
Okay, so can it be over the counter here? I mean, here.
It is also over the counter here.
No, I would look at it from other perspective also. The very fact that US FDA had given it a label of a drug category now as a new drug, that means it has some potency in the molecule itself. From the nutraceutical segment, if something has moved into the category of drug, I think there is, both the sides, they will be now looking at more stringently about passing through definitely the bodies from that. At the same time, they must have seen the potency of the molecule by which it is coming into that category. And what you have said is right, because the very fact that it has been available as OTC in US, so it has been used by it and people are consuming it.
The second question that you answered for is that, so about drug accumulation, is there any drug holiday?
So it accumulates in the adipose. It has a very long life in the adipose, and it then discharges from the adipose. So if you stop taking it, so say you took it for 3 weeks, you will have very high levels in adipose. You stop taking it, it then discharges from the adipose for the next 2 weeks. For 2 weeks, it keeps discharging, so you will still see it in your blood, because these stores that have now banked them will start releasing them.
All right, but do you need to give any drug holiday to prevent it?
No, none. The only issue, potential issue, is blood thinning. So generally speaking, nothing reported yet, but before surgery, we stop it before 48 hours.
And one more similar question, that for how long can tocotrienol be given? So
we have 3+ years. We have 3+ years every day.
Without the thing.
Yeah.
So the dosage which it is being used, say from 30 milligram to 200 milligram, you are still going in a very safe zone. In fact,
no, we in all our human studies use patient-based studies, 200 milligram twice a day at 400 milligram. And in our dose escalation study, in stroke patients, we went up to 800 milligram.
In fact, what is probably is happening because we don't have probably the labs what is checking vitamin E levels. Now, have you ever asked for a vitamin E levels? Anyone? Up till now. You know, unfortunately, as a clinician, we ourselves don't know what are the levels. In fact, in India, there is only one lab, Dr. Lal's Path Lab, which is doing vitamin E level. And I was just checking out, the cost of one test costs 4,500 rupees. 4,500 rupees, and probably down the line, 10 years back, even vitamin D was rarely asked for. Now we have seen we are doing it, and then we realizing, oh, so many people are deficient. So probably we don't know what is the prevalence of vitamin E, whether they are in the normal range or there are people who are deficient in it. And once we do it, then probably we know. We still don't have any data. But the point is, till we have the test which will come down in an economical range, we will not be in a position to ask for it, right? So I think with this, we will have to close the session because, okay, one final question because I got a signal to close down. Yeah, madam, final question.
You mentioned about palm oil. What if somebody uses palm oil in eating, cooking? And second question is, in Ayurveda, almond has been known as vitamin E. So can you elaborate on that?
Regarding palm oil, if I can answer.
Yes.
Ayurveda new vitamins?
No, almond, sir. So Ayurveda mentioned almond, and almond has vitamin.
So if you look at the doses that have been used in studies, 30 to 200 milligrams, the actual content in palm oil, absolute is 0.08%. So you have to take about 80 to 160 ml of palm oil, which is a cup full, to get the dose necessary to give you a benefit. So you have to take it as a supplement. You cannot take it from natural sources.
Palm oil also has a lot of saturated fats and all. So it may not be that good, you see. Unlike coconut oil, which is medium chain, coconut also is high in saturated. But this is, that's why not very well recommended. Tocotrienols do neutralize part of it, but not completely. So it's not the first oil to be used.
Yeah. So due to paucity of time, we will have to close the session. But please give a big hand to our panelists, Dr. Chandan Singh, Dr. Manchanda, Dr. Roy, and Dr. Goswami, who had done a fantastic work. We are really thankful to the entire delegates who are all over here with such an active participation. And of course, we have a lot of questions which has come from the various webcast CMEs which are there in almost 18 to 20 cities across India. So we are, of course, we are not able to communicate, but they are able to listen to us. So we are really thankful to them for their active participation. Thank you so much for the patient hearing. Thanks a lot. And of course, the unrestricted educational financial grant given by Sanofi for this, we are thankful to them. Thank you.
So we are late for the next session, which is on wound care. And I think it will be, we'll give speakers 5 minutes to upload their presentation and we'll start right then. Let's get started.